Hey everyone, welcome back to my channel. My name is Chasen. I'm an acute care nurse practitioner. Today, I want to talk about one of the most important topics in critical care, vasopressors and inotropes. These are medications that are used almost every day across all ICU specialties. Yet, surprisingly, I have talked to quite a few nurses who don't really understand how they work, other than they raise the blood pressure. So, for you folios who have no idea how they work, sit back, put on your reading glasses, and pay attention. These are some of my favorite drugs in critical care, and as a nurse, you just gotta know these things. By the end of this video, it's my goal that you will be able to understand the physiology of hemodynamics, recall the functions of adrenergic, vasopressin 1, and angiotensin 2 receptors, define what vasopressors and inotropes are, understand the pharmacology and application of vasopressors, and provide appropriate nursing care for patients receiving vasopressors. A 67-year-old male with no medical history presents to the emergency department with altered mental status. His temp is 102 degrees Fahrenheit, heart rate 114, and blood pressure is 70/42. Now what? Well, with critical patients, sometimes you have to shoot first and ask questions later. In order to rescue this patient, we need to rapidly increase his blood pressure to ensure all of his organs are getting perfused. And one of the best ways to do this is with the use of, you guessed it, vasopressors. In critical care, one of the most common reasons for admission to the ICU is hypotension or low blood pressure. Patients with a low blood pressure can experience shock, which is a state of inadequate delivery of blood to the organs and tissues. Without adequate blood flow, also known as perfusion, there is not enough oxygen and nutrients to sustain normal metabolism, and the starved cells eventually start to die. The body has many natural mechanisms to support the proper flow of blood to all parts of the body, but during certain disease states, these normal mechanisms can fail. Thankfully, modern medicine has the ability to artificially raise the blood pressure to support perfusion. This is accomplished through the use of vasopressors and inotropes. It should be noted that there is a distinction between blood pressure and blood flow. They are related, but not necessarily synonymous. You can have a quote-unquote normal blood pressure, but still have inadequate delivery of oxygen to the body. I used to teach basic hemodynamics to new nurses according to this slide. But instead of reviewing each of all of these components, today I'm going to discuss a very simplified version. Perfusion to the body can be modified by 4 mechanisms: preload, afterload, contractility, or heart rate. Depending on the cause of the hypotension, you have 4 options by which you can intervene. You can give fluids to increase the preload, start vasopressors to increase the afterload, start inotropes to increase contractility, or use chronotropes or external pacing to increase the heart rate. Since this is a presentation on vasopressors and inotropes, we're only going to focus on these 2 mechanisms. So what are vasopressors and inotropes? Simply put, both vasopressors and inotropes are chemical squeezers, hence the squeeze it character on my title slide. Vasopressors squeeze the arteries to increase systemic vascular resistance. Inotropes squeeze the heart to improve cardiac output. But how do these drugs trigger this squeeze? If you recall, the autonomic nervous system has 2 divisions, the sympathetic and parasympathetic nervous system. Within the sympathetic nervous system, we have receptors called alpha and beta adrenergic receptors. Hormones called catecholamines can bind to these receptors to produce an effect within the body. When catecholamines stimulate alpha-1 receptors, they produce vasoconstriction. When beta-1 receptors are stimulated, there is an increase in heart rate and contractility. Most nurses know that beta-2 receptors are in the lungs and are responsible for bronchodilation, but there are also peripheral beta-2 receptors that produce vasodilation. Most vasopressors and inotropes work by stimulating one or more of these receptors. In addition to adrenergic receptors, blood pressure is also regulated by 2 other neurohormonal mechanisms. Vasopressin 1 receptors and angiotensin 2 receptors produce arterial vasoconstriction when stimulated. So just to recap, systemic vascular resistance is mediated by alpha-1, vasopressin 1, and angiotensin 2. Now that we understand the mechanisms of how vasopressors and inotropes work, it's simply a matter of rote memorization. When you learn about each drug, you will realize that there are just a few pure vasopressors, and there are no pure inotropes. Any inotropic drug also vasoconstricts or vasodilates. This technically creates three categories: vasopressors, inopressors, and inodilators. As you can see, although we call norepinephrine a vasopressor, it is more precisely an inopressor because it vasoconstricts and produces some degree of inotropy. The pure vasopressors include vasopressin, phenylephrine, and angiotensin II. Vasopressin is a peptide hormone that hits the V1 as well as other vasopressin receptors. It produces vasoconstriction, has no direct effect on the heart, and has a duration of action around 20 minutes. Phenylephrine is a non-catecholamine alpha-1 agonist, and likewise, it vasoconstricts, has no direct effect on the heart, and its duration of action is around 5 to 20 minutes. Angiotensin II, trade name Giapreza, is still a relatively new drug at the time of this video. It is not widely used and almost no one has any experience with it. As such, it is generally not included in the list of available vasopressors. Perhaps in 5 to 10 more years it will be included in standard vasopressor education. The next category is the inopressors, although in practice it is almost never referred to as such. We just call them vasopressors, or pressors for short. Norepinephrine is probably the most commonly used pressor. As Dr. Sarah Krager puts it, norepinephrine is not always the best answer, but rarely the wrong answer. Norepi is a catecholamine that has a strong affinity for alpha-1 and a little bit of beta-1. Strong vasoconstriction, a tiny bump in inotropy. This particular recipe makes it very ideal in many situations. Its duration of action is only about 1 to 2 minutes. As any experienced ICU nurse can tell you, in just the time it takes to hang a new bag, the blood pressure can fall drastically. Epinephrine is also a catecholamine with strong effects on alpha-1, beta-1, and beta-2. Epi is appreciated for its stronger inotropic effects, but at the cost of increased dysrhythmias. Its duration of action is around 2 to 5 minutes. The last inopressor is dopamine. Decades ago, this medication was the first-line vasopressor, but has since fallen out of favor. It has a moderate effect on alpha-1, beta-1, and dopamine receptors. It is only occasionally used for bradycardia. If you have a physician ordering dopamine as a first-line vasopressor, call the cops and send them to vasopressor jail. I'm kidding, but please have a discussion with them about their choice and consider switching to epi or norepi depending on the clinical situation. The last category of drugs are the inodilators. In practice, we refer to these as just inotropes. Dobutamine is a catecholamine that strongly hits the beta-1 and beta-2 receptors, causing inotropy and some vasodilation, which is ideal in patients with heart failure. Like other drugs that stimulate beta-1, dysrhythmias are your main concern. Its duration of action is about 10 minutes. Milrinone is a drug that functions differently than any other medication I have discussed thus far. It does not stimulate any receptors. It is a phosphodiesterase 3 inhibitor, which increases intracellular calcium release and reuptake. This produces strong inotropy and vasodilation. Its duration of action is much longer, clocking in around 8 hours. The last drug in this category is isoproterenol. It's almost never used as an inotrope, but since it strongly hits the beta-1 receptors, it does have that effect. Isoproterenol is mainly used to treat bradycardia. Its half-life is relatively short, but effects may last up to an hour. For patients receiving vasopressors, there are certain responsibilities you have as a nurse. Vasopressors can only be administered in a critical care setting with continuous ECG monitoring. There needs to be titration parameters ordered by the physician, for example, to keep the MAP greater than 65. Vital signs will be checked every 15 minutes when actively titrating drips. Vital signs can be checked every 1 hour if not actively titrating drips. When you chart drip rate changes, they should correspond with the vital signs. Vasopressors should preferably run through a central line for safety, but do not delay starting them if you do not have one. Remember to order your next bag long before the current one runs dry. And if extravasation occurs, notify the MD immediately. These are all general recommendations, so be sure to follow your own institution's policies. I hope you found this video helpful. If you like my content, please consider subscribing, and I look forward to teaching more in my next video. Thanks for watching.